Hello, everybody. Thanks for joining us. This is Amin Mohammed, and we're so glad to be at your service. For second session of the International Online course on Information Management Systems in Nursing, as lecture sessions held in 4 weeks, every Saturday, and for next month, we have self-study sessions. If you haven't registered yet, you have the chance to make a registration till there's 1 day left to each lecture session. This course is directed by Dr. Khater Ceylani from Department of Intensive Care Nursing and Nursing Management, Vice Dean of International Affairs of School of Nursing and Midwifery at Tehran University of Medical Sciences. This short course is moderated by Dr. Asiye Darvish from Department of Medical Surgical Nursing of Faculty of Nursing Midwifery at Tehran University of Medical Sciences. Previously, our team presented a national short course on Nursing Informatics in 4 sessions on February and March. In this course, we have Nursing Information Management Systems. Before starting the present course, I sincerely appreciate our 2 outstanding pioneers with brilliant nursing informatics experiences, Dr. Marisa Wilson and Dr. Melody Rose from United States, and a great specialist in health information management, Dr. Tanya Azadi from Iran, who, in addition to their academic teaching experience, are the author of valuable informatics books, articles, and papers. Thanks for accepting our invitation, and we look forward to your great lectures. For this session, we have Re-Envisioned Informatics Essential Competencies for all nurses, presented by Dr. Marisa Wilson, Interim Department Chair for Family, Community, and Health Systems at the University of Alabama, Birmingham, School of Nursing, Associate Professor Coordinator for MSN Nursing Informatics Program, Director of Graduate Leadership Pathways, Doctor of Nursing Science from Johns Hopkins University School of Public Health and Nursing. She has been a licensed RN since 1994, a faculty member in the Executive Doctor of Nursing Practice, which is DNP, post-BSN DNP, post-MSN DNP, and MSN program at UAB, which is University of Alabama, Birmingham. She is active in nursing informatics leadership, the Academy of Nursing, AMIA, which is American Medical Informatics Association, and HIMSS and Tiger. She's a board member of Commission on Accreditation for Health Informatics and Information Management Education, and member of the AMIA AHIC work groups. Dr. Wilson is a task force member for the re-envisioning of the AACN Essentials and team that revised the ANA scope and standards of nursing informatics practice. Hello, Dr. Wilson. How are you? Happy to see you again.
I'm good. I need to shorten that introduction for sure. Basically, that all means I have to herd a lot of big cats into one direction, which is not always easy, but I am very happy to be here and present you with some information about what we're doing in the US. So are we ready to go?
Yes, but before starting this session, I will launch the poll and our dear participants will answer the poll. Thank you. About 70%. I'll close the poll in a few seconds. Thanks for answering the poll and pre-test. And we'll have the lecture of Dr. Wilson. Dr. Wilson, ready to service.
Okay, I am going to share my entire desktop because I hope to be able to link to some links. So can you see my desktop?
Yes.
Good. Okay. So I am hoping to be able to relay to you some kind of complex information, but it's important for you to understand how we got to where we are in the US. And I'm speaking from a US perspective, but I also have international information in here also. But how we got to where we are in the US with informatics education, as well as an informatics specialization for nursing. So I have to explain some of the complexity. So we're going to talk about ensuring competent nurses working in technology and data-rich environments. And I'm talking about not only informatics nurses, but all nurses, because they all work in these environments. So I have a few objectives for this class. I want to help you understand from a US perspective how we differentiate competencies, accreditation, certification, and licensing, because these all drive what we're doing. And I want to explain some of the external forces that are driving everything we're going through right now with competency changes, which change all the rest of the stuff in Objective 1. And I want to explain to you some of the issues we're having when we're trying to cross the education practice gap to try to meet the needs of the people who hire our nurses of all types. I also want to confirm that this is not just the US alone, that there is work being done on international and interprofessional competency harmonization efforts, which means we're trying to pull all of our competencies together. And I want to help describe and provide resources that will help you build the bridge. And as usual, I will provide these slides to Dr. Darvish so you can have them with all the links built in. So first of all, just so we define and we're all on the same plate, as we say, skills are specific learned abilities that you need to perform a job. So I have a skill to dress a wound or whatever. A nurse informatician can be a skilled programmer or can build a screen and such, but that doesn't necessarily mean that they have a deep competency. A competency represents a person's knowledge and behaviors that lead them to be successful on their job or their role or their occupation. So although I may have a nurse informatician who can build a screen in an application, that doesn't mean that they're a competent informatician, because that informatician has to be on top of being able to skillfully build a screen. They have to solve problems. They have to be an analytic thinker. They have to communicate up and down the level of hierarchy. They have to collaborate with peers. There are a lot more things they need to do than just build a screen. And in the US, I will tell you that there are many, many people out there who think that a nurse informatician builds screens, and that's it. And they're sadly mistaken when they explore a master's program in informatics and find that there is a whole lot more to it than building a screen. So other terms I want to define: academic standards. These define what a student should be competent to be able to do in a specific time. And this is defined by AACM. Oops, we got some cute little guy in the back, or girl. Educational accreditation in the United States, and I know this is not the same for other countries, our government does not necessarily oversee the products that we put out at a school, whether that's a elementary school or a high school or a university. Those are done by external organizations that come in and look at the school, and they measure them against what the standards should be for a student graduating in that thing from that school. And accreditation is extremely important in the US. Without accreditation, a student cannot get financial aid. And as you know, the US educational system is very expensive and is not government paid for. They cannot necessarily go to graduate school. In some cases, if you graduate from a program that's not accredited, you can't sit for a licensure because there's no guaranteeing the public that you know what you're doing. So students must look for a university that carries an accreditation so it doesn't impact their future. It's much like a hospital accreditation. And for those who are familiar with the Joint Commission and the International Joint Commission, they come in to a facility and they look at everything. The facility must do a self-assessment, external peer assessment, and if they find that you are not providing quality standard care, you can be in big trouble. And in the US, again, that means with our Joint Commission, we cannot get reimbursed for the care that we give. So it's a big problem. For a university, if you're not accredited, if you don't follow those standards, you can't deal with your students. So how do we figure out what those standards are? Well, a lot of those standards are coming from the populations we serve, the hospitals we send our graduates to, the society, etc. And remember, a university, and this is my opinion only, and I came from the operational world into academia, a university is like a factory, right? We have to put out a product that meets the need of the people who will hire them, that they will care for, that the populations they serve. It's like a factory. And we need to always keep our fingers on the pulse, those of us in education, as to what the needs are of the people we serve. Who are our stakeholders? Who do we have to meet the needs of? We cannot be producing a product that cannot meet the needs of what our today's world is. So at UAB, we work very hard on the left side. That's our magazine cover, to craft and build and teach and guide and mentor students who can cross that bridge in the middle. And literally, there is a road between the School of Nursing and the hospitals across the street, who can cross that bridge and successfully do what those guys are doing on the right-hand side. And that is an actual picture of students with faculty members, CRNA faculty members, teaching those students how to go in and prone those patients during COVID, okay? So that we could send teams of students and faculty in to do that for the nurses, because evidence drove that that's what was needed for the care of very sick patients. And they were doing that in University of Alabama, Birmingham Medical Center, a 1,200-bed hospital, which became COVID central treatment for the sickest of the sick, hundreds of times a day, just going through and doing that. So that was a need we had to meet. So other forces shape us. We have things that push the school to produce students that can do certain things. We have government policy sort of coming down on our head at all times, do this, do this. And then we have the leeward side, or the faculty end, that is sort of pushing and shaping everything we do. And I view the whole academic response to all these forces as sort of like that big ship on the right-hand side. We're sort of this ship going across through the ocean, very heavy, and we're being told, turn around, change course, go slow, go fast. And we have a hard time doing that, right? We're not like a little speedboat that can immediately change. It takes a lot of work and a lot of effort to change the courses, the curriculum, the programs, the faculty. It's a lot of work to constantly be meeting the needs of the people we must serve. So why do we do that? Exactly for this. Why informatics are we bothering with all of this work? Exactly what you see in front of you. These are images of nurses in the US totally immersed in technology, from an ICU setting to a home setting, to working with the robot in the far right that's delivering water all over the hospital, to working with homebound elders. You see that on the lower left with a robot that calms the dementia patient down, to nurses monitoring patients from various places within a home setting. I wanted to show you this, and I'm not sure if I can play the YouTube, but it's buried in here. This is a hospital in the US with no patients in that hospital. It's called Mercy Virtual. It's in St. Louis, Missouri. Every one of their patients are in their home. And the nurses and the doctors that are caring for the patients, they go to this building and they monitor their team of patients in their homes, in the communities every single day without have them in that building. And I'm not sure if the YouTube will work.
I was fortunate enough to be in the ICU when they started.
Do you see, can you see and hear that?
Yes.
Program, but I never thought that there would be a program that they could build where we could make such a difference in patients' lives in their home.
So in some ways, we're going back to the days when the physicians would make house calls. We're making house calls. But
you will have it. It's at the bottom of the screen. I encourage you to look at that video because this is the first hospital we have in the US totally virtual. And they're pushing more and more this way, where hospitals may be hybrid, some parts of it dealing with virtual and some with patients in there, and other additional hospitals in this way. So please look at that YouTube, no patients in that building. So who plans, analyzes, develops, implements, and evaluates? Well, competent nurses do all this. Competent informatics do all this. Nurse specialists do that. Informatics researchers do that, and transformational researchers all plan, analyze, develop, implement, and evaluate the kinds of technologies I just showed you, including that virtual hospital. Okay, competencies. Oh, this is the thing that generally makes everybody kind of sleepy, okay? It's a lot of hard work. It's a lot of effort. But in the US, we have several organizations that oversee competency development that touch nurses in some way, shape, or form, whether it's all nurses or whether it is informatics nurses or whatever it may be. The American Association of Colleges of Nursing, otherwise known as AACN, oversees all the academic nursing universities in the US for the most part, about 900 of them. These are universities that are producing nurses at the baccalaureate or higher, all the way up to PhD. We do have educational programs in the US that are 2-year degrees. They are not overseen by AACN, but we work with them. We are also guided by the competency development that occurred within the American Medical Informatics Association, or AMIA, the Advanced Health Informatics Competencies. Although those are for, and we will go into more detail about these, but those are more geared toward interprofessionals. They have implications for the graduate prepared nurse informaticians. And because we're moving into the world of population health and not just individual patient health in the US, we also have to look to the public health population health forums for their expectations for competent nurse informaticians who work with population health programs. So they're there. So we have to educate and be able to hire competent healthcare professionals. So we have to develop those competency expectations for our students and graduates. We have to develop those students and graduates to be competent, and those are two different things, because you can develop the competency standard and then you got to teach them and measure them. We have to then build curriculum that will build competence graduates over time. We have to figure out how to assess the competency. And remember, it's not just the skill, It's knowledge and behavior. We have to be able to demonstrate both and that they achieve competency over certain time periods. We have to ensure that our graduates can be certified and licensed regardless of what they are. Again, that's driven by the competencies and the standards. We have to make sure our programs can be accredited by, in our case in the US, the Commission on the Accreditation of Nursing Education, the CCNE. We have to be able to mentor the new graduate into their new role. That's not always easy. We have to change the hiring expectations of employers. We still have employers out there who will hire any nurse who's tired of working with patients and knows how to use a computer and give them the title of nurse informatician. That person has no idea what the full spectrum of the expectation is. And we have to provide continuous professional development to those we graduate, because the nursing informatics profession and informatics in general and technology does not stand still. It's constantly changing. So our expectations come from societal demand. What does society want? And right now, society is very connected with digital health, and they're demanding this in our hospitals. We are being driven by public policy. We're driven by practice needs, by policy, regulation, and in our case in the US, payment and finance, because we do not have government paid for healthcare except for our older people. We do have that. But a lot of us are under private insurances, and they have all sorts of things that they want the hospitals and the providers to do in order to get reimbursed. And our schools are charged with producing professionals that meet all this. And are we doing that? Well, I can tell you, my Re-Envisioned task force, who began our meetings 2 years ago, meeting with an executive team and practice partners from across the US. And we were academic, we were a variety of kinds of people in the task force, from big schools, small schools, private schools, not private schools. Our practice partners who represented, they were chief nurse officers from large academic medical centers, small rural hospitals, ambulatory clinics, all kind of things, public health. That group of practice partners said, no, you are not meeting our needs. The product you're putting out does not help us with what we have to deal with today. You need to fix it so that your nurses can help us do what we need to do in today's day and time. And we were initially a little upset, but then we had to take that in and realize there was a lot of truth to that. Our healthcare partners, our practice leaders, were being pushed by lots of forces themselves. And that was pre-COVID. It got worse when COVID struck. And our nurses, whether they were bedside nurses or master's prepared nurse leaders or nurse informaticians, did not always have the skill set to be able to do what those practice partners needed. So we began this cycle, right? Practice needs, competency development, curriculum development, accreditation, and licensure. We got through the practice needs. We heard all the stories from all the practice partners. We spoke to all the stakeholders of what we needed. We went into competency development. That took a year. Lots and lots and lots of discussion to upskill all nurses, which impacts nurse informaticians. Went out on listening tours pre-COVID, listened to all the nurse faculty, get scared, complain, be supportive, every different iteration. Had lots of discussions. COVID struck. We had to lock down. We couldn't do face-to-face meetings. We set up virtual meetings, did that, finished and finalized the competencies, sent them to the American Nurse at the AACN board, who approved them April 6, 2021. Now we are in the process of helping nurse schools develop curriculum that meet the need, and we're working with our accreditation bodies. So when they come in and look at the schools, they know what they're looking for. And we're working with all of our licensure bodies so that they can include important information in the testing of nurses for their license in the US and the licenses of advanced practice nurses that include informatics competencies. So some of the essentials, now this is for all nurses, but it impacts the nurse informatician significantly because we increased the baseline expectation of all nurses, right? Which then pushes up the expectation of the specialist in all the specialties, including nurse informatics. So in the Re-Envisioned Essentials, we basically went with the philosophy that the essentials are the core competencies for professional nursing education, that nursing is a discipline, that we have to advance the discipline in nursing, that we want to ensure that we include those aspects of the liberal education like social sciences, psychology, history, and that we move to competency-based education. And this is very important because those schools are going to have to indicate how these students, how they're measuring that they see that those students know and can do things, not just they can pass a test, but that they know and that they have certain behaviors. This gets a little tricky. So we also have some other drivers on top of all that in the 21st century nursing education of the US. We have got to indicate diversity, equity, and inclusion. We have to make sure we are considering all the racial, ethnic, diverse populations in the US, because we know that certain of our populations have very bad health outcomes. We have to make sure our nurses understand 4 spheres of care, that it's not just acute care, that it's long-term care, that it's acute care, that it's population health, that it's palliative care and hospice, that informatics and technology is embedded, is key, that our nurses are engaged in experience, that we have formed academic practice partnerships, which mean we in the academic side are partnered with our practice settings so that we're producing what they need and they can let us know what we need to produce, and that our nurses understand that they're in for lifelong learning in their career. So we came up with 10 domains. 8 of these domains for the competencies are in line with our interprofessional partners in the US, our physicians, our pharmacists, etc. However, we added some two additional domains. First of all, knowledge for nursing practice encompasses evidence-based practice. Person-centered care encompasses the fact that the person is at the center of everything we do. Population health was one of the things we added. We are going to be moving nurses out of the acute care setting into the community and population, which for some of you is not a big deal. You've always been there. In the US in the 40s and 50s, we built a lot of hospitals. We took all the nurses out of the populations and the communities, and we stuck them in the hospital and left the populations and communities with very little nursing support. So we need to get back there because we cannot keep this circle with people coming into the hospital, going right out to the community and population, getting sick again and back in. Scholarship for nursing practices, we have to continually push our evidence forward. Interprofessional partnerships. Again, our nurses are not just working in isolation. They work with physicians, they work with social workers, they work with physiotherapy and everybody else. Systems-based care. Our nurses have to understand patients just don't live in the ICU. They go from the home to the emergency room, to surgery, to the ICU, back to med-surg, out the door to the community, and back again. So it's one long system of care. Information and healthcare technology, we added that in. We did not want that hidden in the other competency domains. Professionalism, which means we expect all nurses to be engaged in their professional organizations. And we also want them engaged in their own personal, professional, and leadership development. Their learning does not stop at the front door. So all practicing nurses need to have these, and all practicing nurses need to include informatics and healthcare technology, because we know that several organizations have identified that one and population health in terms of our domains have big gaps, right? The HIMSS Tiger EU US International Work Project sent out surveys to thousands of nurses. What did they find? Not surprising. Nurses in general lack knowledge and skills in informatics. The providers lack knowledge and skills in informatics and information technology. The training for them doesn't seem to be available. And what training is available is of poor quality. So we have a big gap for our domain 8. So that supports that. We also know our practice partners voice concerns to our task force about certain of our domains, and those included information technologies and informatics. They said their nurses, all of them, are not able to be full partners. Just recently, the National Academy of Medicine just launched the 3rd edition of Future of Nursing, Leading Change in Health. They said the same thing. Not only did they say nurses need to be leaders and practice to the top of their license, they said population health and informatics, not so great. You guys need to do a better job. We also know from many, many self-assessments that students take in some schools, and all of these are the literature, that students identify that although they may know how to use Facebook and that kind of stuff, when it comes right down to it, they lack informatics competency. So a little bit about this Future of Nursing 2020-2030 Charting a Path. Again, this was a consensus study by the National Academies of Science, Engineering, and Medicine in the US. They just released this May 11th, so just a few weeks ago. I have the report link here and the YouTube of it. They identified things we must focus in on. Our nation's culture of health. We have to reduce health disparities and improve the health and well-being of the US population in the 21st century. A lot of that rests on information technology and health informatics and the nurses that oversee that. In the US, we spend more money than any country, developed country, in healthcare. Yet our gross domestic product, we spend a bigger percentage of that. It's ridiculous. We're off the chart when you look at the chart. However, our health indicators are horrible. We have an infant mortality rate among some populations that's no better than some developing countries. We have maternal mortality issues. We have people dying from things they should not be dying from in this day and age. So we have a lot of work to do, and the work is around more than just buying very expensive equipment like certain MRI machines and stuff. It really is about the health and well-being, and how are we going to manage the health and well-being of our populations, but utilizing the technologies that we have available to us. So our Future of Nursing Leading Change said, just recently launched, we have to transform our practice, transform our education, transform our leadership, and meet the need for better data on the healthcare workforce and the populations we serve. So this is a huge driver right now. So here's just one example of our need, right? This was just recently, we lived through this, and that was COVID and the associated sequela, mortality, morbidity, and the like. Teasing apart the data, we understand that a lot of our folks who fared the worst in COVID fared the worst because of certain social determinants of health. That's health inequities, economic inequities, crowded housing, baseline health conditions, stressors, etc. Those people that scored highest on all these things A, we're at highest risk for contracting COVID, and B, we're at highest risk for having bad outcomes or death. All of this stuff needs to be addressed as part of what we're doing, including monitoring it from information technology. The Future of Nursing 2020-2030 report, and I put little arrows, right? Basically said, nurses have to improve the health of individuals, families, and communities by addressing social determinants of health. This can't be done without informatics and information technology. We have to train and make sure we have competent nurses that are able to do this and move this forward. And we have to be able to respond in emergencies. And we have to do it in a resilient way to ensure the delivery of quality care and improve community health. And you can only do that with the backbone of information technology. Again, the challenge for us in the US compared to other countries, we have the very highest amount of money we spend on healthcare. It's ridiculous, but we have some of the poorest outcomes. And all of that came into stark picture with COVID. If people didn't know it before, they know it now. And factors like race, ethnicity, income, sexual orientation, the conditions of where you live, work, play, all impact your health. It's more than just the medical care you give, and it's not going to be possible to tackle this without competent nurses who can deal with informatics and information technology, and competent, skilled nurse informaticians who can build the tools that will help do that. So their vision, the future of nursing, achieve health equity in the United States and build that on strengthened nursing capacity and expertise. So again, this is just the nurse's role in addressing health equity and health care in the US. Underscoring all that, technology, demographics, care models, emergencies, and attitudes. Most of that comes to us right through information technology, informatics processes, and the data we collect. So let me just give you a little bit of a primer on sort of the relationship between the competencies, the standards, and the accreditation in the US. Can you all see that blue triangle? Can you see that? Okay, good. All right. First of all, competencies for students on the left-hand side. For us in the US, this is pushed by several things. The bottom level is our entry to practice nurses, our BSN and our accelerated masters. Now in the US, an accelerated master's student is one who has a previous degree and is coming back to be a nurse, and they don't want to get another bachelor's degree. So they go into a master's program, but it's a generalist. Those programs are really pushed by the AACN Essentials, and in this case, the Re-Envisioned Essentials. The next two levels up, the Advanced Practice Essentials, these are for people who are getting a master's degree or Doctor of Nursing practice. Note that I did not include PhD in here because in the US, PhD degrees are governed by our graduate school, not by necessarily these, although we work together to ensure that material that the DNP and the PhD must be taught together is done in an efficient way. The DNP is not a research degree, it's a practice doctorate. And what that means is these students are learning their practice, whatever that may be. It could be nurse practitioner or nurse anesthetist or nurse informatician in a big system way. And they're learning how to evaluate evidence, implement evidence, translate evidence, and evaluate the programs that they put in. That's what they're doing. The competencies for these students are pushed by things like the ANA scope and standards of nursing informatics. Yes, thank you, Melody, working on her DNP. ANA Scope and Standards of Nursing Informatics Practice, which is for all nursing informaticians. And then we have another layer on top, ANIA, the Advanced Health Informatics Competencies, which covers all professionals, health professions that are achieving a master's degree in some form of informatics. On the right-hand side, the accreditation. So at the bottom, and for all nursing schools, mostly in the United States, their accreditation is driven by the Commission for Collegiate Nursing Education, or CCNE. At the top, the specialty, informatics in our case, is overseen by the Commission on the Accreditation for Health Informatics and Health Information Management, or CAHIM. So CAHIM will come in and look at all health informatics programs to make sure you are delivering to those competencies and those standards a good, strong, solid curriculum. So they will accredit the informatics part. CCNE credits all the nursing part. And that is a little, okay, so I need to, you want me to mute my speaker? Okay, let me see if I can stop that thing. Okay. All right. I may have to do that at the break so I can take down and go into my system setting, if that's okay. And I will try to stop that noise. Okay, thank you, because I have to go into my system setting. Okay, so those are those relationships. And then if we go on the other side, we have licensure and certification. At the bottom for us in the US, our entry to practice nurses all have to sit for what's called NCLEX, which is their nursing license. And that's the entry. Our nurse practitioner students have to sit for licensures. And yes, in Kurdistan, Iraq, your DNP is Diploma in Nursing Practice. In the US, it's Doctor of Nursing Practice. So it's the highest level terminal degree for a practice doctorate. On the right-hand side, licensing and certification in the US for an informatics nurse or an informatics person. There are several depending on what you want to do. The American Nurse Credentialing Corporation has an RNDC. That's sort of the foundational licensure. It's built on the competencies. It's built on the standards. It gets changed every time the competencies and standards change so that people are being tested on what they were supposed to be taught. AMIA is now working on advanced health informatics certification for non-physicians. They already have the one for physicians. It's for people prepared at a master's degree, regardless of what you are, nurse informatician, medical informatician, whatever you are. HIMSS, of course, has CAHIM and CPHIMSS. CAHIM is more entry level, and CPHIMSS is for someone who has at least 5 years experience in leadership in an information technology role. Those are just some examples of certifications that our nurse informaticians can sit for. So let me talk to you a bit about the essentials. Let me do a deep dive. And remember, this is all nurses, not just informatics nurses, but it sets the foundation for the informatics nurse because we're pushing up the expectation of all nurses. So the American Association of Colleges of Nursing, again, told us we have to be focused on diversity, equity, inclusion, the 4 spheres of care, disease prevention, health promotion, chronic disease management, restorative care, and end-of-life care. We have to be very focused on systems-based care, which means our nurses have to understand movement of people, populations, communities across the care spectrum. Informatics and technology must be embedded. Nurses have to be engaged and experienced. We have to have those academic practice partnerships, which means we have to join hands with our hospital partners if we're in a university and vice versa, so we can make sure we're meeting each other's And we have to ensure our nurses have career-long learning because it never stops, including the informatician. Our 10 domains, I went over them with you. Knowledge for nursing practice, person-centered care, population health, scholarship for nursing practice, quality and safety, interprofessional partnerships, system-based care, information and healthcare technology, professionalism, personal, professional, and leadership development. Again, all nurses. Concepts for nursing practice that all of them have to understand across the domains: clinical judgment, communication, compassionate care, again, diversity, equity, and inclusion, ethical practice, evidence-based practice, not Heath policy, health policy, sorry about that, and the social determinants of health. We have a 2-level model now. We've got the essentials at the entry to practice level and the essentials at the advanced level. So the entry to practice, again, are those coming in with an initial degree, and advanced are those coming in to get a master's or a DMP. I'm not going to read all this. This is the preamble of Domain 8. That was my thing that I had. And that's Informatics and Healthcare Technology. And it basically provides our faculty out there with the fact that informatics and information technology is not computer repair. It is not programming. It is not just the EHR. It is how we use data, information, and knowledge with technology to advance our practice and care for our patients, our families, our communities, and populations in this technology-rich environment that we all live in. And these are the competencies and sub-competencies, right? So you're going to have a copy of this document, and this is only Domain 8. This isn't the other 9. The other 9 are there, and I've given you a link for all of them. So Domain 8, competency number 1, and in information technology, health and healthcare, informatics, healthcare technology, there are 5 buckets that I put the competencies in. First, all nurses have to understand all the information and communication technology tools that they will use with patients, communities, and populations. It's not just the EHR. That's all they generally think about. Secondly, they have to understand how these information and communication technologies are used to gather data, create information, generate knowledge to guide our wisdom. Third, they have to understand how these technologies impact the workflow, the quality and safety within our workflows. Fourth, they have to understand how these technologies and data exchanges impact communications we have with each other, with our patients, with our providers, with our communities, etc. And then lastly, we have a section on our own ethical issues and legal issues related to data, technology, exchange of data, because although we have an ethical statement for all nurses, information technology tends to have its own specialized kinds of statements. On the left-hand side are the competencies and sub-competencies we expect of an entry to practice nurse by the time they graduate. On the right-hand side, building upon the left side in this table, that's what we want our advanced nurses to know. So you can see on the left-hand side, all nurses have to be able to describe those technologies. All entry to practice nurses have to identify them and how they're used in the care setting. And that's EHRs, PHRs, monitors, apps, whatever they're using. Barcode medication administration, Pyxis machines, the whole 9 yards. They have to identify basic concepts of these tools. They have to effectively use communication tools. They have to describe the appropriate use of multimedia applications in healthcare. And they have to explain the importance of a nurse's involvement when these technologies are being planned, being selected, and being implemented. Now, on the right-hand side, with our advanced nurses, they have to start leading, looking for best evidence for the application of these tools within various settings. They have to evaluate unintended consequences. And this is all nurses at the advanced level. Now, the informatics nurse has got some more stuff going on up here, which I will get to. They have to develop a plan to influence selection and implementation of technologies. They have to think about the fiscal, the financial impact, and identify information and communication technology workflows and processes. The second group, the second bucket, use information and communication technology to gather data, create information, generate knowledge. Again, enter accurate data when chronicling your care. Explain how the data entered on one patient impacts public and population health. Many of our entry to practice nurses don't understand. Whoa, goodness gracious, something happened there. Let me just get back to where I was. Sorry about that. That was kind of odd. My mouse went crazy. Okay, sorry about that. Apologies. They don't always understand that the data that they enter on a patient doesn't just stay with that patient, that in the US it goes beyond that patient. They have to use appropriate data when planning care. Our advanced nurses have to be able to generate information and knowledge from those technology databases. They have to do the evaluation of consumer health literacy. They all have to use standardized data to evaluate decision making, and they have to understand why, for some nursing concepts of interest, we are not just making up words, that we have to use standardized terminology. Let me make sure I'm monitoring this too. They have to, again, participate, the entry to practice nurses have to participate and evaluate various patients and populations for their health information literacy. And believe me, right now in the US, this is a huge problem, a very huge problem with health information literacy, particularly as it surrounds the COVID vaccine and COVID and wearing masks and all that stuff. The third bucket, use information and communication technologies and processes to deliver safe nursing care to diverse populations in a variety of settings. Remember, we got those 4 spheres of care. So it's not just the patient in the ICU or in the bed in front of us. So they have to demonstrate the appropriate use of information and communication technologies. They have to use those technologies to support the nurse-patient relationship. They have to identify how emerging technologies influence care delivery. Right now, last time we talked about artificial intelligence, right? We are talking about robots. We're talking about all sorts of other things. Every day, there's something new. How does that influence care delivery? Nurses have to be involved in that. The advanced nurses have to be doing more evaluation and formulating decision-making plans and appraising the roles and evaluating uses and moving things forward. Bucket 4, use information and communication technologies to support documentation and communication among providers, patients, and all system levels, at all system levels. So again, the technologies being used to communicate between each other, between our patients and us, between our populations and us. How do our systems do that? Our entry to practice nurses have to participate in that, explain the role in that, understand the basic concepts in that, and the interactions. Our advanced nurses have to, again, assess best practices and move them forward. Use information and communication technologies in accordance with ethical, legal, and professional and regulatory standard and workplace policy. So they need to understand it's more than HIPAA. It's more than that. It's more than providing, making sure hackers don't get in. There's a whole lot of other things. We have issues sometimes with our nurses, our young nursing students, not realizing you can't take a picture of a patient and put it on the internet. That's a violation of patient privacy. Stuff as simple as that to what are those legal and regulatory requirements they got to be aware of. They can't go scrolling through their neighbor's file. because their neighbor is a patient and they want to see what's wrong with them. They can't do that. That's an ethical violation. They have to understand that accurate data actually has an ethical implication. Our graduate students really have to look more into pushing those ethical and legal issues associated with the use of technology. Right now, the 21st Century Cures Act that happened with us, that has a huge, giant implication for information technology, informatics, and data, has a piece of it in there that started April 5th of 2021. And when I tell my nurse practitioner faculty and my nurse practitioner students who write notes, clinical notes, like the physicians do in the US, that patients can now see those notes, they aren't even aware of that. Patients can now see everything in their record, and they can see the note that you wrote about them. So you want to make sure the note is helpful, is going to move the patient forward to better health, not judgmental, etc. So, those kinds of policies, those kinds of regulations have to be constantly monitored and taught. So this all shapes these internal and external forces shape the specialty. So the future of nursing, our practice partners, what our patients expect, what our foundational essentials are pushing. This then, again, as I said, pushes up the expectation of our specialists. So again, an example of a driver, social determinants of health, it's in everything. I've said it a bunch of times, health equity. Social determinants of health is being embedded in the way our nurses practice, the way our nurses respond, the way our nurses are to think, the way our health systems are to react. It impacts our nurse informaticians because somehow those risk factors have to be assessed, have to be calculated, have to be scored so that we know that patients are at risk for something that's going to have an impact on their health. And then as a system, we have to figure out what are we going to do about it. So if we determine that a new diabetic patient is at risk for food insecurity, and yes, we have that in the United States. We have food deserts. We had lines of people waiting for food during COVID. If we determine that, how do we tell a newly diagnosed diabetic who lives in a very poor community with a food desert, meaning they don't have access to good grocery stores and food, that they have to eat healthy food, if we cannot help figure out how to get them to that? So we have to be able to refer them. If they are having problems with transportation and can't get to healthcare, we can't set up 5 appointments and then say they didn't show up. Well, they didn't show up because they can't get out of their building and they can't get in, right, to the doctor. So how are they going to monitor their health? We are working with Uber and Lyft to provide those rides to people who qualify into their doctor, their provider, into the hospital when needed. All that has to be done by the information systems and the data that's collected. And all these things directly impact the health. So other examples that we are monitoring in social determinants is, of course, income and social protection, education, unemployment, work-life conditions, food insecurity, housing, safety, early childhood development, social inclusion, non-discrimination, structural conflict, and access to affordable health services. So none of that can be collected manually. All of that needs to be collected via information technology, data assessment of the patient's data collection, management of that data in some way, shape, or form, and movement of those risk scores over to referring patients to services or whatever they need. We also have some other policy drivers. Again, as I said, in the US, medical care accounts for 10 to 20% of our contributors to health outcome. The National Academy of Medicine says we have to deal with this because we're spending a higher percentage of our gross domestic product on medical care than any other developed country, yet our outcomes are among the lowest. And I know I've repeated that several times, but it's really important. So again, these things are driving the push toward improved nursing competence in informatics and information technology, and then are pushing up the work with the nurse informaticians and how can we get them to a much higher level so that they can understand complexity like what's in front of you, data and information standardization and use, the interoperability standards advisory panel from the Office of the National Coordinator. How do they make sure that what we are having to do to direct to get to deal with social determinants of health and health inequality, how do we do that? Well, we have to do that using information, data, information, and knowledge, and information technology. It is not possible to do that utilizing paper and pencil very well. So it has to be done that way. And nurses are key involved in this. Our practicing nurses are key to understanding this whole process and using social determinants of health as an example. And our informatics nurses are key to developing the products, the interoperability processes that we can use to make this happen. In the US, we also have to deal with what is called value-based payment models. Some of our practices are not going to get reimbursed at the level they need to without demonstrating that they're doing these things, that they are accountable to their patients, that they are communicating with technology, that they're gathering data, that they can indicate what their problems are, that they can measure outcomes, that they can relay those outcomes over to the reimbursement agency so that they get paid. So it's not business as usual over here anymore. So again, the essentials impact the specialist. And I ran through all the essentials before for domain 8, which was informatics and information technology. There's a whole lot more, and they all work together. So you have things like leadership, communication, interprofessionalism, and all that working together. But I wanted to call out informatics so that you know that we are pushing up the learning among all nurses relating to informatics and information technology, which is now having an impact on the nursing informatics specialty. So, oops, where is my thing? Here it is. So the nursing informatics specialty, and I'm trying to see if it's break time or not. I'm sorry. I'm looking at the chat. Nope, it's not. I'm trying to manage chat and communication. All right. So the informatics specialty competencies, which are being impacted by the essentials. So we are currently in the process of going through a revision of the American Nurses Association Scope and Standards of Nursing Informatics Practice. We're in our third revision. We are also in the process of working through the American Medical Informatics Association Advanced Health Informatics Competencies, which granted covers all professions, but impacts informatics graduate programs that are accredited by CAHIM, which includes the nursing informatics programs. So the book, well, we just went through a public comment period, and we're going through all the comments and putting them together. However, because the new essentials came out April 6th and got approved, we need to go back into the scope and standards of nursing informatics practice and make sure we're building upon the essentials, not repeating the essentials and putting them on the nurse informatics specialist, if that makes sense. We don't want to put the same level of competency expectation that all nurses have on the specialist. So that is still underway. So the ANA Scope and Standards of Nursing Informatics Practice, Again, we've revised the definition of nursing informatics, and these are all still draft. Whoops. Am I still there? Okay, I froze. We are still in a draft mode, but nursing informatics is now being defined as the specialty that supports nurses, patients, healthcare consumers, and other stakeholders in their decision-making to achieve desired outcome through identification, management, communication of data, information, knowledge, and wisdom via the use of information structures, processes, and technologies. That's the current revised draft definition of nursing informatics. This is a draft model that we built that tries to pare down exactly what the nurse informatician is responsible for. So you can see on the outer ring, we have identification, integration, communication, and management. On the inner ring, we have data, information, knowledge, and wisdom. And then underneath of those, we have actions that the nurse takes, the nurse informatician takes, the skills and competencies, the knowledge they must have in order to do this. So in order to be able to identify concepts of interest of nursing and any healthcare setting, we have to have the correct data. In order to have the correct data, we have to be able to name it, which means for those things that need to use standardized terms, we're using standardized terms. We need to be able to collect it in an efficient and effective way. We need to be able to organize it in a way that doesn't violate cognitive processing standards. To form information, again, how do we organize that data so that we can help our end users, whether they are patients or nurses or whoever they are, understand how can we define that information and help them interpret it. With knowledge, they're going to understand, integrate, interpret, and with wisdom comes from experience, but we are going to ethically apply the information that we have. We are going to use the information we have to create new discovery and to understand how healthcare works around us. So this is a model, again, draft, we're still working through this, that we try to pictorially represent everything, the fullness of what the nurse informatics specialist does. In the center, you'll see our nurses, healthcare consumers, patients, and other stakeholders. And then around the outside, you see decision-making to achieve desired outcomes. That's in the kernel of what we're trying to do. Oops. So informatics has a long and storied history. My internet is very weak. Can you hear me still?
Yes,
okay.
We have connection with you.
Okay. So nursing informatics in the US has a long history. In fact, we were the first specialty. We beat medicine. They're still working through this. We had the first graduate program in nursing informatics established in 1988 at the University of Maryland School of Nursing, where I worked for several years, followed by the University of Utah very quickly. Now there are hundreds of programs in the US. Some are very strong, some of them aren't very strong, and we are trying to make them all very strong. The American Nurses Association, which recognizes specialties of all nurse types, recognized nursing informatics as a specialty in 1992. So it always makes me laugh when I hear somebody say, oh, this is new, it's new. I'm like, no, it's not new. It's 1992 was a bit ago, right? Like 30 years now, so it's been around. The first certification program in the US was established in 1992. And the first ANA Scope and Standards of Nursing Informatics Practice textbook came out in 1995. So we have a long history. And again, I manage I direct one nursing informatics program at the master's level. but we have many in the US. And as I said, some are strong, some are not so strong. We are trying to make sure that they are all strong and all graduating competent informatics nurses at the graduate level through the usage of the KHIM accreditation process that eventually will become a mandate if our graduates, nursing informatics graduates, want to be able to sit for the Advanced Health Informatics certification by AMIA, not just the AACN's RMBC, but this other certification. So that's something we're trying to do. So why do you care about nursing informatics? Because yes, there's a lot of informatics. There's pharmacy informatics, there's medical informatics, biomedical informatics, population health, public health. There's all kinds of shade of informatics. Informatics is a broad multidisciplinary field that encompasses lots of stuff, from data analysis in health insurance to IT and medical practice management. It's very broad. In general, health informatics graduate students can come from any health profession or no health profession. So I work with a colleague who runs a health professions master's program. She's got students in there who got their bachelor's degree in computer science and want to enter the health informatics field. They have no health background whatsoever. Nursing informatics is a subdivision of clinical informatics, which is a subspecialty of health informatics. The difference with nursing informatics, we have the same core of cognitive science, information science, computer science, communication science, etc. But we do this with the lens of nursing. Nursing science is added on the top. So nursing informatics is a subdiscipline of informatics that focuses on nursing care and nursing operations data. It really ensures that the nurse informaticists are clinicians first and information managers second. So why do we feel this is important, those of us in nursing? Because nurses are, and I think that's on my next slide. Yep. Nurses are most often the biggest workforce in healthcare. Nurses are most often the ones who are using technology 24 hours a day, 7 days a week on a nonstop basis. Nursing care makes a difference to patients, populations, communities. However, we often have a difficult time measuring the impact that nurses have on patient outcomes. And we often have a very difficult time as nurses ensuring that we have a voice at the table when technologies are brought in, that they are not negatively impacting the work of the nurse, the thinking of the nurse, the processing of what nurses have to do, the efficiencies of their care, taking them away from patients. We need a voice at the table, which means you have to have nurses, all nurses, who understand this, and nurse informaticists and informatics nurse specialists, these are slightly different things, who can lead this stuff. And if they are not trained with a nursing lens, sometimes they get lost among everyone else. And sometimes what I see when they graduate with a degree that's not nursing informatics focused, where they have been supported to develop their nursing thinking and their nursing leadership and their nursing skills and communication, they become the screen builders for the physicians. They become the people that help the team, but not the leaders of the team for the same work that's going to impact their colleagues. So let me go back here. Nurse informaticians understand the optimized clinical workflows for the nursing workforce and all workforces, but particularly nursing. They know how to achieve operational efficiencies if they're given the training and skill and ability to do that. They understand the complex communication needs we have, and they understand the need to provide quality care. And I will tell you, when my nurse informatician graduate students are in a course with the health informatics students, and they are working on a workflow diagram about maybe an order entry process, their colleagues do not understand why, their non-nurse colleagues, that the provider or physician doesn't just write an order and the nurse do it. No question, just do it. And why, if it's not done and marked as done in so many minutes, that there's a problem. They do not understand that. And my nurse informaticians are always shocked. My nurse informatics students are always shocked that that's the thinking, that their non-nurse informatics colleagues, students, want to know why. No, wait a minute. Nurses take an order and they give it. They don't understand that. No, nurses have to think about that medicine they're putting in someone, or their IV they're sticking in someone, and make a judgment about, is that right, wrong? Should I do that? Is it going to kill the person? What's going on here? Was it a mistake? Nope. They think we just do it. And why, if they're not seeing that it was done in so many minutes, they can't just make a alarm, an alert. You're not done. Our nurse informatics as a specialty has to be constantly guided by data, information, knowledge, and wisdom. It's not all about the data going in. And when they're not trained to think beyond, goodness, I don't know why this is happening like this. My mouse is going crazy. Okay. When they're not trained to think beyond just data entry screens, we get nothing but systems with giant data entry screens, screen after screen after screen after screen, that burdens the nurses, provides them with not useful information, and no ability to synthesize out the knowledge that they need for their practice, let alone deal with wisdom and decisions they're making. So we need the nurse informaticians. We really need the nurse informaticians to work toward clinical decision support to help the nurses. So nursing informatics has a value, and this is something that we worked on quite a bit in this ANA revised scope and standards of nursing informatics practice, and it's still getting revised in this draft period, because we want to make sure people understand that there is a value to being a nurse informatician, a value for you as the student, a value for you as a school, and a value for the people that hire you. First of all, we have that unique combination of nursing and informatics profession and practice in this rapidly evolving landscape. We understand nursing and healthcare delivery operations. We understand the whole process. We know how people come in, move, go this way, go that way, and go out the door. We understand that, and we understand how to make that happen. Sometimes not very efficiently. We also understand how data, information, knowledge management can be accomplished for individuals, groups, populations, and communities. We also know we need executive informatics leadership during this accelerated digital age. We need a nurse informatician at the highest executive level of an organization to oversee all these technologies and how they impact nurses that are coming in, and how you're going to extract the data out to truly understand what nurses are doing. We have to, as nursing informatics people, influence health policy. We have to be able to integrate those socio-technical approaches with the science of quality and safety. Socio-technical meaning, how do we pull together the people, the processes, the organization, the technology, the patterns of work, along with quality and safety in our realm? And how do we learn across the spectrum of the healthcare system? We have multiple practice areas for nurse informaticians. They're not just in one little role. Our nurse informaticians go out and they work in management roles, administration, leadership, clinical informatics, data management. They're in analytics now. They're working in quality and safety departments. They, of course, are doing research and evaluation as PhD graduates and DMP graduates. They're working in compliance and in integrity. They're doing coordination, consultation, facility integration. And yes, they are nurses, and note, nursing knowledge is working as a Superman for helping all these people. Yes, indeed. That's exactly what we're doing. And we're trying to ensure that our nurses have the tools that they can be to be super people, right? So we're doing all this. So when I have a student that comes in and says to me, well, you know, what kind of job will I get? I have to ask them, what do they want to do? Because the future for them is not limited by a specific role. I right now have 4 nurse informatician master students getting ready to graduate who are working with 2 nurses who funded a startup company, right? So they're learning how nurse informaticians can be business leaders, entrepreneurs, and go through that whole startup process with funding and getting clients so that they can develop and deliver product that meets need. So that's very exciting for these 4 who are working with that particular group. So HIMSS has an eye toward Nursing Informatics 2020 in the workforce. They provide us with some background. They have done a survey every few years among practicing nurse informaticians to find out what's going on. And you have the link here so you can go and see it. But nurse informaticians are playing a key role in healthcare. And these are international respondents, not just US. They are often the driving forces behind development, implementation, optimization of digital systems. 68% of the respondents work in a hospital or health system. 53% work in some sort of magnet hospital, whether that's Magnet in the US or Magnet International. 41% work in an EMRON stage 6 or 7 facility, a HIMSS EMRON. And if you're not familiar with EMRON, those are the levels that a hospital achieves as they become more and more technological and more integrated. And 7 is the highest level. That's like total integration. Everything's integrated. Data's flowing outside of you to patients and other providers. It's quite wonderful. 41% of our nurse informaticians work there. I wonder if that has anything to do with their high EMRON ratings. 6% in the US work in an ambulatory setting. Ambulatory is the clinic, you know, where they go to see their provider and they're not in the hospital. That we're growing. We're growing population health with nurse informaticians. We're rebuilding the public health informatics infrastructure and public health nursing with, again, nurses. For a while in the US, we sort of dismantled our public health structure in favor of dumping all that money into hospitals. And then you see what we got with COVID. It highlighted our very weak public health structure that we had to reinforce just to give out things like vaccines and educate people. So we're trying to rebuild that again. President Biden is putting money in the public health infrastructure, thank God. 66% of our nurse informaticists hold graduate degrees. So what is a magnet designated hospital? Okay, a magnet process is, and I'll send information on that. But magnet hospitals are hospitals that have gone through a rigorous process to examine the leadership, the committees that nurses sit on, their the ability for nurses to input into their facility, talk about issues that need to be fixed, go out and find solutions for those fixes. So magnet is a big deal. It basically is a process that empowers nurses to work to their highest level and have an amount of responsibility for the healthcare setting and the health outcomes of their patients. It allows them to have ability to connect and have committees and say in what happens.
Hello again, this is Amin Mohammadi. We're back to today's lecture with Dr. Wilson. We have participants from 30 different countries over the world. So good morning, good evening, good afternoon, and good night. Dear Dr. Wilson, we're at your service. You're all eyes and ears.
Well, you've all been very patient, especially with my dinging email. So I'll try to explain a couple of things that I saw in the chat box, and I think I turned off the ringing email. It is annoying. I'm like Pavlov's dog. I hear the ring and I'm like this. So yes, there is a listing on Enron stage 6 and 7 facilities in the HIMSS site. So if you go to HIMSS, the HIMSS website and look up Enron, there's all sorts of information about what they all have to do to get to a 6 or a 7. It's quite complex. And yes, there is always discussion in the US about nursing informatics. Should we combine it and make it health informatics, blah, blah, blah. There are two sides to that argument here in the US. First of all, it is a specialty, okay? Recognized by the American Nurses Association and has been before anyone else had one. Those of us who continue to keep nursing informatics as a specialty, and there are many of us, many schools in the US that do recognize that when you put the nurses into health informatics, they lose the focus on nursing. And they totally become focused on being helper to generally the physician. Okay? That often is what happens because they've been in that sort of role. Often as a nurse coming into this, they have a very hard time making the change and transition to being a leader, independent in their practice. And that's what we're trying to do. Can they work with their other colleagues? Yes. Do they work with their other colleagues? Yes. Okay, why do governments or accreditation bodies even allow the establishment running of schools or programs without them? Well, that is a problem, Elvis. We have schools that are called for profit here in the United States. And yes, it is a trap for students who graduate from those schools because they do not know any better. They don't know any better. The lecture, I've got another 15 minutes. The students don't necessarily know any better. They don't understand about accreditation. So we in academia have to constantly let them know that. And yes, it is a problem because we do have schools that are predatory, take students' money and they can't do anything with it. Magnet is an interesting thing, and I can send some information to Dr. Darvish, but it is magnets. The reason it's magnet, like a magnet, you want to attract and retain the best nurses, right? And keep them. So magnet looks for the structure within hospital. Magnet is the process that goes in and reviews the hospitals, or the hospitals, looks for the structures that the nurses work in, how they have autonomy or not. Do they have their own ability to input in committees and make decisions about their practice? They look at evidence-based practice that goes in. It's a whole big thing. And every 5 years, they have to get recertified to be magnet. The hospital that's affiliated with my university, University of Alabama, Birmingham, is on their 7th magnet accreditation, which I think is a big deal. It's a huge thing for a hospital to undertake that review of its work and its workforce, and the voice nurses have. Let's see. In the US, like I said, there are many, many schools who graduate nurses with degrees in nursing informatics, and those nurses work in a variety of settings. And yes, some schools have gone over and moved into health informatics, and there's a big debate about that among the AMIA academic forum, particularly those of us who run nursing informatics programs, trying to see what that does for the role of the nurses in this in this field. We do not want them to become the builders and the helpers of the physicians, and that's often what we see happen. and that's anecdotal. So international nursing organizations, there are a lot of them, and I just quickly grabbed these. I can't always say they're the most up-to-date. Get more information for study materials for the Informatics Nurse Certification course, ANCC. That's all out there on the ANCC, the American Nurse Credentialing Corporation website under Nursing Informatics. They will tell you about the study materials, but they're being updated for the new scope and standards, right? Because the test always follows the standards and the study materials have to follow the test. So that's all in process. So these are just some examples of nursing informatics communities, some more formed, others less, but you've got it in Australia, Canada, England, Ireland, Korea, New Zealand, Singapore, Taiwan, and of course the US has quite a few of them. And I will tell you in Taiwan, Poland Chang is so busy covering Taiwan and mainland China. Dr. Poland Chang, he's got dynamite nurse informaticians over there who do unbelievable work. Same with Korea, Dr. Hane Park, who did a lot of the groundwork in Korea on nursing informatics. They are doing unbelievable stuff. So explore those. I'm sure there are more. HIMSS has an international and interprofessional informatics competency group. And that group, Dr. Darvish is involved in that. This HIMSS Tiger International Task Force, I'm involved in that. That's how we met each other. But there is a long history of HIMSS Tiger doing informatics competency work that's international and now interprofessional, okay? Tiger started out being just nursing, but has kind of gone into interprofessional. So it started out with the 2016 EU-US e-health work project. The links are here and you will have access if you click on the hyperlink. Went into the HIMSS Tiger International Task Force. Oh, look, a typo. That's not uncommon for me. And then the HIMSS EU Beyond Recognition. Then I wanted to highlight an article I found with Farzandipour, Mohammedian, Akhbari, Safari, and let me uncover this last name, Jabali, who did self-assessment of nursing informatics competencies in hospitals. That's available on the online Journal of Nursing Informatics that comes out of HIMSS. That was 2020. They looked at informatics competency. I believe it was in Iranian hospitals, I'm assuming, given their names, that's probably where it is. So you may also want to look at that. We are all struggling a bit with coming up with a faculty and student self-assessment of their informatics competencies recommendation. There are several of them that exist out there. SANIC, TANIC, there's a whole lot of them. We need to make sure that those competency assessments meet the needs of the current essentials, right? And what we're trying to do with the ANA scope and standards. Lastly, we have the AMIA AHIC, which is out there. Good old AMIA AHIC. This is relatively new. The American Medical Informatics Association Advanced Health Informatics Competency Grouping really came about so they could create a physician board subspecialty at the master's level, okay? The physicians wanted to have a subspecialty in health informatics. There's nothing different about this stuff than a nurse informatician does either. So there is a separate group that are non-physician focused that are looking at the same AMIA health informatics competencies for non-physicians. They did a big job survey in AMIA, and lo and behold, they discovered, regardless of what your health profession is, these are very common elements of your informatics job. It is not only the physicians who have these, nurses and pharmacists and everybody else. And the physicians were quite shocked that we all share this same core model of what we have to know. The AHIC domain incorporates a statement on knowledge, skills, attitudes, and abilities. And I believe I included this in resources. So it gets very specific about what knowledge you need to know, what skills, what attitudes and abilities you have to have. Again, those KSAs, those competencies. Remember, however, we don't want nurses to get lost and to wind up being the people who just build screens for docs, right? We want to have nurse informaticians who can deal with the issues that nurses have, that can support nurse decision-making, that can help with nurse outcome measurement, that understands the complex workflows, efficiencies, operations of nurses who are at the patient bedside 24 hours a day, 7 days a week with the patients. They have their own needs to help understand the nursing impact on patient outcome. They have their own needs to understand how to make systems that work for nurses better. They have their own needs to understand how to build clinical decision support rules to help nurses, because we represent the largest workforce globally. These are the AHIC competencies you will see here. There's nothing new and nothing specific only to physicians, right? You got to understand health. Well, we do know our nurses understand health. Generally, they need more understanding on healthcare delivery from its bigger sense. And they need to understand more about population health in its bigger sense. But they all need to know about information science and technology, social and behavioral sciences. How does our social and behavioral aspects of our life impact our health? They need to understand about the information science and technologies, the human factors and socio-technical systems. They need to understand how all that is applied to health, and they need to know how to be professional. So this is AHIC, nothing new under the sun. This was initially developed just for physicians. Then they went out, as I said, and they did this job survey and found, look at that. These other people share some of these same things. Surprise, surprise. So let's talk about some issues for informatics. We've got professional development of the current workforce. We know there are huge gaps. Our practice partners tell us that our current workforce, whether they're bedside nurses, cannot participate in these projects adequately. They don't know how to participate. They don't know what their role is. We have professional development needs for faculty. I heard that all over the place with the essentials, basically calling out informatics and information technology in a very specific way, and population health. When we did the listening sessions, our nurse faculty were suddenly realized, our nurse faculty who were not informatics trained, that they really didn't know what informatics was at all. They thought it was teaching people how to use an EHR, or worse yet, how to use the learning management system so they could do hybrid courses. So we have big professional development needs for faculty because in the schools in the United States, across the country, there are not enough prepared nurse informatics faculty people to teach in all those schools. So how are we going to help our non-informatics nurse faculty teach the regular nurse? So our nursing informatics faculty can be focused on the informatics people. We need expert consultation on assisting with curriculum change. They don't know how to embed this stuff in what they're doing. We need appropriate clinical experiences so that these nurse informatician students and nurses at the bedside understand how this all works together. We need designated healthcare systems that will hire those with competency, not just those who are tired nurses who know how to use a mouse, unlike Dr. Wilson, whose mouse goes crazy. They need designated roles for competent nurses in both population health and informatics. They need programs that will allow the competent nurse to practice to the full extent of their training and skill set. And for an informatics nurse, that means being able to support the nurses, not being a screen builder for the physicians. Then we have bold action. There's some resources that are out there that are trying to help. We have bold action taking to transform nursing education in the United States to strengthen this workforce. Because the essentials were released April 6th of 2021, just about a month or so ago, the AACN is now bringing together a group, well, it's been continuing, so that we can develop a toolkit to help upskill people. HIMSS Tiger and the Informatics Educator Resource Network, which is part of the virtual learning environment, is going to address some of the concerns about upskilling all nurses and upskilling the nurse informatician, because we've built a higher bar among all nurses. So that's another resource. We've got another group I'm engaged in, Nursing Knowledge Big Data Science. You know, this is off looking at big data science and shareable, comparable data. We have several work groups. I'm the co-chair of the education committee. We are building teaching packets to help, again, our nurse faculty understand the complexity in data science and shareable, comparable data. So those are resources that are underdeveloped, plus many, many more that those of us in the nursing knowledge, big data science group are trying to keep coordinated and aligned. So that was my slideshow, and it's very complex, I understand. And I understand that it is in many ways US centric, but that's of course the system I am working in. But there are many, many international implications for this. We work with many international partners across the globe. In fact, at 3 a.m. my time, I will be delivering the second lecture to nurses working in informatics roles for the Ministry of Health for Dubai. I did this last week, I'll do it again. And they're getting foundational introduction to nursing informatics content. Some of them are in the process of getting their graduate degrees in nursing informatics in Dubai. In the United Arab Emirates. So that's what we're doing for them. And we do this for others. And yes, all the lecture materials will be shared. I will actually add some more information in there about magnets, since that happened to be interesting to people, and HIMSS Emron. So you can see the progression of a hospital as it gets more and more sophisticated, more and more technological, more and more connected, and why it's important to have trained nurse informaticians in those hospitals and beyond. So I am looking at chat box, and I am happy to answer verbal questions that you may have if people can come in verbally. And it looks like my dinging did stop, so I was very glad. And I hope this wasn't too confusing, because it is a very complex, confusing, and moving topic. Moving meaning every time we turn around, something else is pushing us like that boat. And we're like a big boat trying to turn around. We're not very, quick like those little boats. I'm monitoring. I'm not seeing any other questions. I can provide that other information. Dr. Darvish, when I send the PowerPoint, I will send it with information on Emron and Magnet. I appreciate your patience.
Yes, Dr. Darvish is disconnected. I would appreciate if we could first launch the poll, because we're running out of time. And then after that, we can have the question and answer. Is that okay for you, Professor Wilson?
Oh, yes. Thank you, Dr. Azadi.
Oh, thank you very much.
I did not realize Dr. Darvish was disconnected.
Dear participants, we have about 3 minutes for filling the questions. Thank you.
Elvis 04 asked me if accelerated MSN program for people who already, can they go right into the DMP? We've created a bridge for them so they can go into the DMP. Yes. And right now we have sort of an issue with the schools who converted their master's nursing informatics to DNP nursing informatics, because we don't have standards and competencies yet that differentiate out a master's from a DNP. I'm trying to round up a group of people who will work on that. What's the difference between a master's prepared informatician and a DNP prepared informatician is still yet to be teased out. How are we doing with the poll?
We have 55% of participants who applied the poll.
Okay.
There's 1 minute left.
And it looks like everybody's doing pretty good on the poll. And Kevin,
Yes.
Regards from Maryland via Birmingham, Alabama. You're in New Jersey, so you're not far from me.
68%. Thank you. We'll wait a few seconds and then I'll end the poll.
Okay, and while you're ending the poll, Zora asked about our practicum. Our nursing informatics students do a practicum. That's part of the requirement for their certification. They have to have at least 200 and, well, it's going to actually be more, 200 and some hours of practicum. So in their last 2 semesters, they work with a nurse informatician. For those 2 semesters, they're in the site. They are doing projects, they are learning, they are part of the team. I guide all my practicum students to the site and with the work that they do with their preceptors. We want to make sure they're able to go from student to this new role with a good background and practical experience. And yes, you can connect with me via LinkedIn. And VN wants to know about nursing in our hospitals based on simple nursing care program and an old-fashioned practice. The question is, do we need to have an informatic nursing as a major topic? I think if they have any kind of technology that they're dealing with, regardless of what their practice is like, you need to have someone who has some understanding of that whole process. Or else you'll never move beyond into a more sophisticated level. And I'm going to put my email here if you want to email me. And you two will be on that dinging list when it comes to me. So that's my email, which I put in. Whoops, sorry, I didn't send it to all. Okay, it's coming. There, that's my email. Yes, my program, Nursing Informatics, is a Master's of Science Nursing, MSN, in my school. That's what we offer. University of Maryland offers a Master's of Science, MS. Yes, and a lot of schools in the US, we're trying to pull together a list of all the schools that offer Nursing Informatics Master's programs. Believe it or not, it's harder than you think. But we have probably several hundred schools in the US. Yes, University of Maryland, my University of Alabama offers a master's, University of Utah, University of Kansas, Vanderbilt University, Columbia University. There is many, 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 many. And then there's some big for-profits like Walden, Capella, etc. And small schools too that offer informatics, Masters in Informatics, Nursing Informatics. So Maryland is not the only one. It was the first one. I had the privilege of working there and working with them. I retired from there, the privilege of being part of those initial teams that developed it, but it's not the only one. Yes, Melody, telehealth. Telehealth is a telecommunications technology. It fits in with the data, information, knowledge to wisdom acquisition. You're dealing with patients and populations and providers. It fits right in with informatics, and it's part of what we do. It's not just the EHR. Yes, many of our programs are online. Now you want to make sure, are you online or are you distance accessible? In many schools like mine, our students just aren't out there online doing their own thing. We do a lot of synchronous work with them. We have lectures we deliver with them. They may be sitting in a different place, but we all come together at times for various things that we do. We try to maintain a high touch. We don't believe this is a topic that you want them just sort of out there on their own doing by themselves, because there's a lot of complexity to it. And it is important they have more than 100 hours practicum in hospitals with highly qualified. Yes, the American Nurses Credentialing, to get their RNBC, they have to have at least 200 hours of precepted practicum. In my school, they take 2 courses, 2 credits, 120 hours and 120 hours. So that's 240 hours, right? If they are wanting a DMP, they need 1,000 hours, 1,000 hours of clinical and practicum experience across their time of doing this doctorate. And yes, it's not easy to change their nursing mentality away from being a doctor assistant to being a professional nurse with your specialty and your own practice. Yes, international students can participate. There's some trickiness when it comes to distance accessible courses. So you have to really look at the school and what they're allowed to do with students who are in distance accessible courses. International students in the US now, well, since 9/11, cannot be in the country, in the US, in an online program. You can be in your own country in an online program based in the US, but not living in the US in an online program, if that makes sense. Because immigration wants to check on every international student we have, and we need to know where they are at any point in time. So we do have international students in my school living in the US who are taking face-to-face courses where they're sitting in a chair. I hope that makes sense. Our PhD nursing faculties with specialized study, and yes, we have lots of PhD. I have a DNSC, which is a research doctorate. All my other faculty in my nursing informatics program, I have 2 PhDs, 1 DMP, and me. So yes, they all have an informatics focus. Do I teach any subject to MSc students of NI? I teach a lot of other things like leadership, evidence-based practice, and a bunch of other stuff that whatever they give me to teach, I have to teach. But I teach a lot of the informatics. I see somebody can't fill the post test. And yes, it's time to pray.
The time of the post test is over and it's closed.
Okay, and for NICOVI, our Nursing Informatics Master's Program is under the grouping of nursing leadership. We have 5 master's programs that are considered nurse leadership, and one of them is informatics. So you kind of have to dig down. I'm trying to get them to blow up that website because it's really not that usable. User friendliness was not there, and usability was not their strong point when they developed it.
Okay, thank you very much, Professor Wilson. Does anybody wants to turn on his microphone and speak? That's the time.
And yes, there are programs that offer certificates in nursing informatics if you have an already master's in something else. So that's available. I'm watching the chat. Again, I'm going to give you my email. You can always email me. If you can't find nursing informatics in our website, our school website, that's not so great, too complex, it goes down too deep, I'm happy to send you directly to that. Or talk about anything else you need to ask about. Okay, well, I thank you for all your patience and effort and time and dedication to this topic. As you can see, it's one that I feel deeply about. Obviously, technology is embedded in everything we do, and it's embedded in what our patients do. And if we're not there to help make it better, make it useful, make it helpful, do what we need it to do, we're just going to get whatever we get. And that's the basic idea.
Okay, thank you very much, Professor Wilson. That was really insightful, very informative. I really enjoyed it. And I guess, does anybody wants to speak? Somaye, did you want to speak? Oh, no. Okay, so we guess we can close the session.
Well, I think you want to have everybody turn on their screen so you can get a picture, right, Mr. Mohammadi?
Yes, yes.
Okay.
But before taking the group photo, I have to give you a great Thanksgiving. Before this session, I didn't have clear information about informatics competencies for all nurses and the differences between nursing informatic competencies. Please accept my deepest thanks for your explicit presentation and lecture. Thank you.
Thank you.
At the end of today's meeting, please open your cameras to take a group photo.
And I will tell you that my regular nursing faculty over here who know they're going to have to specifically deal with informatics are struggling. The struggle is real, helping them understand what informatics is. So.
For next session, we have nurses' role in technology selection, design and implementation with Dr. Tanya Azadi. Thank you for following us, staying with us. Dear participants, thanks for staying with us. We're waiting for you next Saturday. We're looking forward to see you again. Thank you.
And I offer my sincerest merci and Khuda Hafiz.
Khada nigehtar. Goodbye. Bye-bye.